thanks to Ajanta team and Dalit Verma sir. But again, when you ask the VR surgeon to talk on viral retinitis, definitely he will be in shock. So as I am, and then these two gentlemen has come up with adrenaline pump to take me out of the shock. And when you have like this kind of picture in your clinical scenario, I'm sure, obviously, tell me what is the most way of treating them, easiest way is to refer them to those two gentlemen or the panel who was sitting there in the morning session who are sitting there. But when you have a viral retinitis, you can't, the life is not that so easy that you can always refer to them. So, but again, I will restrict my talk to ARN, PORN, and CMB retinitis for viral retinitis in those cases. And we'll just, if time permits, maybe some non-necrotizing retinopathies also I'll just touch upon. But preferably, history is one of the most important part. Location, shape, number, the associated other features, whether you have the arteriolitis or optic nerve involvement, how much is the progression. So these are the parameter we need to look into and then go for the treatment. So the most common frequently asked questions are the diagnosis, is it clinical or I need to do the PCR is mandatory for all these cases, and intravitreal always or a systemic therapy can do. How long should be a systemic antivirals? If active retinitis and RD is there, do I operate or a defer? Phenotypic, how much is viral load, how to decide about it, and post retinitis resolution, whether should we continue with the steroid alone. So there are many more questions will be there. I'll try to give you the solution for that. Life cannot be always easy like this. You can have an acute retinal necrosis like this, and then you can have a peripheral coalescing lesion with vitritis and arteriolitis. You are done with the diagnosis, clinical diagnosis. As the American Uveitis Society says, and this was the older method of diagnosing it, you have the scallop peripheral necrosis retina and associated with occlusive arteriolitis, and there is inflammation of the vitreous or in AC. So these are the three criteria was there for ARN diagnosis in initially. Has been again revised, and then the PCR has also come into this. So you have the peripheral necrotizing retinitis, necrotizing along with either PCR positive for HSB or VZB, that is sufficient enough to go ahead for the treatment, or if you have the full blown clinical picture. So either of the situations can have, like, you can go ahead for that. But the most important is that you should have the high level of suspicion for diagnosing them. So I'll just give an example. This is a 44-year-old male doctor and who presented at the initial elsewhere, who has been treated with some granulomatous uveitis and then treated with topical, followed by IVMP, oral steroid, and even the one dose of adalimumab was also given. But the initial mistake was that the vision, even the fundus was not seen. And at presentation, they come up with this. So even after the TACI tap was done, VZB was positive and treated properly and with proper resolution of the necrotic areas. You can have sometimes this kind of central necrotizing herpetic retinopathy, or you can have a non-coalescing peripheral lesion which is just coming up with this. Some amount of the arteriolitis and vitritis may or may not be present there, but if you have the high suspicion from that point of time itself, you can do the RT-PCR and find the viral load and go ahead for the treatment. As I was talking, like picking up from the hints, which was there, like this kind of arteriolitis, this is the arteriolitis areas, or you can have a like this, peripheral scallop lesion. These two can give you the high level of suspicion to, diagnosing. For the diagnosis. But if you are lucky, you can have some supportive evidence associated with systemic features like this. And the most important is that intraocular specimen evaluation for the RT-PCR for the viral, not only the detection as well as the load, how much is multiplication is occurring for that. And some imaging guiding or the documentation tool can give you for the treatment for the following them up for the resolution phase. So like this, if you have an initial phases of viral retinitis, and if you have a ARN in the periphery, obviously you cannot go. But if you have the posterior part of it, you can document. You can see these areas of almost all the area of the retinal thickness has been involved. And in the inactive phase, this area again, if you see, this is the initial area, and this is the area of necrosis and completely thinned out retina with some vacuole formation of this compression. Octa does not have that much of role, only for the documentation of that, how much of the necrosis and the arteriolitis has occurred, and the visual prognosis for that. But for the viral frequency, by doing RT-PCR, VZV is the most common organism, followed by HSV1 and 2. So this is how the different study has given us the data for that. And typical management is IV acyclovir or oral well acyclovir, or treatment with intravitreal treatment with gan acyclovir, steroid, or surgery when the RD develops, regmentogenous RD, especially when it develops. So the common complications are retinal detachment, optic atrophy, vitreous hemorrhage, CME, and ARM, of which first two is the most common clinical scenario. But there was a common belief that if you have the necrotic area, then you can do a barrage for all around to prevent RD surge, retinal detachment. But these retinas are very sieve-like retina, and they are prone to develop of the retinal detachment. In fact, a short pilot study has shown us very clearly that even by doing this prophylactic laser itself, you are inducing the probability of the retinal detachment. So probably we are rethinking of whether we should do the prophylactic laser treatment for this. So if you have like this bilateral ARN with retinal, this is the completely detached area, and this is the sieve-like area, this is necrosed area, and then you do the treatment, and necrosed area completely retinectomy has been done to preserve the central retina. So this is how the patient can get back good amount of the vision. So if you have a high level of suspicion in the initial level, when you have more than 1 crore RT-PCR load, and that can go up to a RT-PCR non-detectable stage by 3 to 6 months time. So this is I'm just giving an example for that. When you have an extensive, especially in the posterior pole involvement, and you have this kind of what you call as a cracked mud appearance without the presence of any arteriolitis, and it is very fast progressing, and in presence of, especially in presence of immunocompromised status, you should think of progressive outer retinal necrosis. Now, talking about the CMV retinitis either can be of hemorrhagic, which typical known as a pizza pie appearance like here, or you can have the granular involvement in the periphery, extreme periphery part of it. But again, they are usually associated with the immunocompromised patient, and most of them are CD4 count is very low. But when you have patient is on HIV, patient is on ART, and the CD4 count may go up, and then you can have a confusing picture of a immune response and active CMV retinitis. So you can have this kind of frosted branch angiitis like picture, and where you can have the hemorrhagic retinitis as well as this frosted branch appearance. So CMV retinitis in non-HIV patient may not always present as a typical kind of presentation what I have described there. Some like malignancy or post-transplant or a local immunosuppression therapy is going on. So in that situation, you can have a localized, a granular, what I have shown you this picture like this, and can, with proper resolution, it can have the healed CMV cases. If you have a juxtapapillary or involving the disc, and this is how it looks like, this has a special clinical importance, because these are the cases are associated, can be associated with the CNS involvement also is higher. So few clinical tips is that these are CMV retinitis is more common in HIV patient in adult rather than the pediatric group. But if you have the pediatric group is involvement, then you can have even the higher CD count also, they can have the involvement. But anyway, nevertheless, this peripapillary CMV retinitis has a high possibility of almost 80% possibility of CNS involvement. So you need to treat them with the systemic therapy properly. So imaging biomarkers are again an ancillary protocol for this. So maybe this is the area where you can see this is a whole clinical picture of CMV retinitis involving one quadrant, and here it is the area of the CNV areas where the whole full thickness retina has been involved into this. So once you have this picture and the high magnification picture, you can see the vitreous involvement of these areas of the vitreous seeding like picture, you can see it here. And when you have the resolution 10 days later, and then at the ultimate area of the same area, if you see, this is the area which has developed the scar here, and this is the retinitis area which has developed the necrosis in this area. So this patient was treated with ART, vanciclovir, and steroid. This is the final outcome with this. And just a few glimpses of the non-necrotizing retinitis. This is a young adult with bilateral sudden loss of vision who was treated empirically with acyclovir and steroid and with a good resolution with some amount of the optic atrophy. And this is another case, post-fever immunocompetent adult who has turned out to be HSV2 positive in ACTAP PCR. And so to ask the frequent test question, so RT-PCR is the diagnostic criteria for as of now, and that can give you the viral load, and you determine the treatment protocol as well for this. And in active retinitis with RD, yes, you should operate and treat them accordingly till the resolution of the disease. Viral load and the virulence determines the treatment protocol as well.